I want to welcome everybody to this week's Dermpath Unknown session. We decided in December just to do a few little shorter segments because everybody's time, we realize, is at a premium. What I'm going to be doing today, and hopefully later in the month, is presenting a series of 5 cases. Some of these entities we've discussed in our board review sessions, but they're holes that I've identified in our standard YouTube library. So some of the entities that we don't have videos for, we've included them in this session and in subsequent sessions. So there's no real thing for today's session, as I'm sure you know from looking at the slides. If you have any questions as we go along, please feel free to put them in the chat. For those of you who are watching this recorded, you can email any questions you have to education@sagisdx.com, or you can email me directly, tdavis@sagisdx.com. April just put my email address in the chat box. Certainly don't mind you texting or calling. Either my cell phone number is 210-416-4815. So that being said, we'll go ahead and get started. Our first case was an example of Bowenoid papulosis. And in this bisected shade biopsy specimen, we can see that we've got a lesion with the architectural silhouette of a papillated acanthoma. If you notice in the central portion of the specimen, the surface is papillated. The epidermis is acanthotic or hyperplastic, and the lesion has a flat bottom. Really has the silhouette, possibly even seborrheic keratosis, or maybe even a condyloma. If we zoom in to somewhat higher power and look at the edges of the specimen, we can see that there's basket weave orthokeratosis overlying an epidermis, which is composed of keratinocytes, which show evidence of orderly maturation. And over at the other edge, albeit a much smaller fragment, we do have a piece of normal epidermis with overlying basket weave ortho. But if we look at the epidermal keratinocytes in the central portion of this lesion, we can see that there in most areas is full thickness atypia of the keratinocytes with disordered maturation extending from the basal layer all the way up to the stratum corneum. And you can see we even have some hyperchromatic nuclei in the stratum corneum. The keratinocytes have nuclei that are pleomorphic. The nuclei are markedly variable in size and shape. There are a few small foci of necrosis en masse. There are apoptotic cells, mitotic figures, and several cells with hyperchromatic nuclei. And so, you know, the presence of full thickness epidermal atypia we associate with Bowen's disease or squamous cell carcinoma in situ. And so distinguishing Bowen's disease or squamous in situ from Bowenoid papulosis at times can be difficult, if not impossible, may require clinical pathologic correlation. The fact that we've got normal epidermis on either side of this shade biopsy specimen, coupled with the fact that it has the silhouette of a papillated acanthoma, should really lead you to consider the possibility of Bowenoid papulosis. From a histologic viewpoint, there's really not much of a way to distinguish those two. And so again, having the clinical knowledge that this was one of several small pink to slightly pigmented papules clustered around the glans penis of a young male certainly would help you out. HPV typing was done on this case, and of course, there was high risk HPV identified. This particular case showed HPV 16, which is a common player in lesions of Bowenoid papulosis. What items could we consider the differential diagnosis? Well, I think on scan, given the architectural configuration, one could consider the possibility of a seborrheic keratosis. However, seborrheic keratoses do not demonstrate full thickness epidermal atypia and disordered maturation with atypical keratinocytes. And rather than having a parakeratotic stratum corneum, seborrheic keratoses tend to have basket weave hyperkeratosis. One could also consider the diagnosis of a condyloma, because this does have the configuration of a condyloma. And indeed, these are human papillomavirus infections, Bowenoid papulosis, but they're just caused by oncogenic forms of the virus. So it's not surprising that lesions of Bowenoid papulosis have the architectural configuration of a condyloma. Of course, typical condyloma will not have atypical keratinocytes and evidence of disordered maturation. And the degree of atypia in Bowenoid papulosis, this is real full thickness atypia, can vary from a lesion like this to just a few scattered atypical cells present throughout the epidermis, depending upon the age of the lesion. So first case, condyloma acuminatum. Our next case, the correct diagnosis was ILVEN, or inflammatory linear verrucous epidermal nevus. This was a much larger biopsy specimen, an incisional biopsy specimen. This was taken up near the head of the neck. You can see several hair follicles and a few sebaceous glands in the specimen. If we focus on the central portion of the specimen, we can see we have a fairly sharply circumscribed zone characterized by epidermal hyperplasia and papillomatosis. And what, of course, is characteristic of lesions of ILVEN are the alternating zones of full thickness parakeratosis in the stratum corneum and compact or basket weave ortho. And you can see there are alternating zones of the parakeratosis, beneath which, as expected, the granular layer is absent, alternating with these zones of compact ortho or basket weave hyperkeratosis, in which the granular layer is intact, all in the setting of a hyperplastic epidermis, which is somewhat papillated. There is an associated perivascular infiltrate of lymphocytes present in these sections, and these mounds of para within the stratum corneum have been likened to bird's nest, and you can see that they're characteristically arranged in fairly regular intervals, seated at the top of the epidermis. What else might one consider in the differential diagnosis? Given the presence of epidermal hyperplasia and parakeratosis within the stratum corneum, one would have to consider the possibility of a papulosquamous eruption, such as psoriasis. In psoriasis, rather than having regular mounds of parakeratosis scattered across the epidermis, one tends to see more confluent parakeratosis. There should be more thinning of the suprapapillary plates, more bulbous reedy ridges, and generally one likes to see neutrophils within the epidermis and stratum corneum. One could also consider the possibility of pityriasis rubripilaris. Typically in PRP, while the reedy are elongated and hyperplastic, the degree of epidermal hyperplasia is not as pronounced as one sees here. The reedy tend to be a little bit more stubby. And you'll remember that the parakeratosis that one sees in the setting of PRP is more staggered with horizontal and vertical orientation, rather than these discrete full thickness zones of parakeratosis that one sees in ILVEN. So our second case, inflammatory linear verrucous epidermal nevus. Moving on to case 3, the correct diagnosis was a pigmented spindle cell nevus of Reed, or also known as a pigmented spindle cell variant of a Spitz nevus. In this bisected punch biopsy from the trunk, one can see a melanocytic lesion, which is relatively small. This was a 4 millimeter punch biopsy, and one can clearly see the lesion fits within the confines of the 4 millimeter punch biopsy. This was probably about 3 millimeters in diameter. The lesion is clearly symmetric. If you draw a line down, halfway down the specimen, one could see that the right and left halves look the same. This lesion is very well cerebrally circumscribed, ends with a nest on either side. And one can see, moving to higher power, that the lesion is composed largely of nests, which are arranged along the dermal epidermal junction. Many of these nests do have a vertical orientation. They're separated from the overlying dermal epidermal junction in many areas by these clefts. There are a few dull pink globules or caminobodies present within the epidermis. There's hyperkeratosis, hypergranulosis, epidermal hyperplasia, and again, a predominance of these elongated nested aggregates arranged along the dermal epidermal junction. Most of the melanocytes are heavily pigmented. And if you take a look at their nuclei, you can see that most have these elongated spindle-shaped nuclei with very little in the way of nuclear pleomorphism. These have uniform chromatin pattern, and there really are not many, if any, mitotic figures identified. This is a largely junctional pigmented spindle cell nevus. There are a few nests of melanocytes down in the papillary dermis. In the central portion of the specimen, there is some upward scatter of melanocytes into the overlying spinous, granular, and cornified layers. But the lesion is architecturally and cytologically very bland, and this pagetoid scatter is present in the central portion of the specimen. And so this has all of the classic features of a pigmented spindle cell nevus breed. Many do view this as a variant of Spitz nevus because, as you're aware, Spitz nevi are characterized by enlarged melanocytes that either have spindled and or epithelioid nuclei. A lot of times in a classic Spitz, one will see a mixture of the two morphologies of melanocytes. One might consider the possibility of a spindled or pigmented melanoma, but this lesion has such benign architectural attributes. Most melanomas are going to be broader. They're not going to be this symmetric. They are certainly typically not this sharply circumscribed, and they would exhibit a greater degree of cytologic atypia of the melanocytes than one sees in this lesion. One could also think possibly about the diagnosis of a largely junctional type of dysplastic nevus, but again, the spindled morphology and vertically oriented nest in this lesion are very characteristic of a pigmented spindle cell nevus of Reed. Okay, let's go ahead and move on to case number 4. Case number 4 was a bisected punch biopsy from acral skin. You notice in the dermis, there are no hair follicles, and we've got a very, very thick stratum corneum. And the correct diagnosis in this case was pustular psoriasis or palmoplantar pustulosis. If we look at the left half of the specimen, we can see that we have a large intraepidermal pustule, which in many areas is subcorneal in location. We look near the surface of the specimen, we can see a small spongiform pustule. There's extensive parakeratosis containing neutrophils within the stratum corneum. And I think especially in the right half of the specimen, one can see characteristic changes of plaque-like psoriasis. There is, again, extensive parakeratosis containing neutrophils within the stratum corneum. The granular layer is absent. There are a few spongiform pustules within the epidermis. The suprapapillary plates in many areas are quite thin. There are dilated and tortuous vessels present within the underlying dermis, some closely approximating the undersurface of the thinned dermal papillae. There are a few suprabasal or mitotic fayers, and the rete are bulbous and very uniform, and the dilated vessels are present within an edematous dermal papillae. This is just a really classic example of pustular psoriasis. Now, obviously, one would need to, in this instance, especially with the pustular dermatitis on a volar surface, one would need to check a PAS to make sure that this wasn't an inflammatory dermatophyte infection. Usually, inflammatory dermatophyte infections don't so closely mimic psoriasis, but you'll always want to carefully scrutinize the cornified layer, looking for the presence of hypoelements either in the H&D stain sections and or get a PAS or GMS stain to rule out the possibility of dermatophytosis in a biopsy like this. Let's go ahead and move on to our last case, case number 5. The correct diagnosis here, this punch biopsy from the trunk, is a response to an arthropod assault. In this particular biopsy specimen, one can see a perivascular infiltrate, which is, let me get my pencil here, vaguely wedge-shaped. The infiltrate is distributed predominantly in the upper portion of the dermis. The papillary dermis is somewhat edematous. One can see pallor across the biopsy specimen. There is a basket weave cornified layer. And while there's a little bit of spongiosis involving this follicular infundibulum, for the most part, the epidermis is uninvolved. There's not a lot of spongiosis. There's not much in the way of epidermal hyperplasia, and the interface is fairly crisp. Within the dermis, there's a perivascular and interstitial infiltrate. And as is the case with most perivascular infiltrates, if there's an interstitial component, more often than not, the infiltrate is mixed rather than mononuclear. And if we go down and take a look at the inflammatory cells in these sections, we can see that we've got lymphocytes around the vessels. There are clearly a few histiocytes here with larger nuclei and a more open chromatin pattern. And there are numerous eosinophils present not only around the vessels, but also located interstitially between collagen bundles. And if one sees a superficial or superficial and deep perivascular and interstitial infiltrate with lymphocytes and eosinophils, and there are a lot of eosinophils between collagen bundles, one always needs to consider the possibility of a response to an arthropod assault or an infestation such as scabies or possibly some type of infestation caused by another environmental mite. So this is pretty characteristic of a response to an arthropod assault. One might consider, given the density of the infiltrate, kind of its wedge-shaped, mixed cell nature, something like an early lesion of lymphomatoid papulosis. In lymphomatoid papulosis type A, which we see most commonly, one would expect to see a few neutrophils in addition to the eosinophils. And of course, one should be able to identify several enlarged atypical lymphocytes present within the infiltrate with somewhat pleomorphic nuclei, frequently prominent nuclei, and they should be CD30 positive. And then, of course, one would get a typical history of lesions that kind of come and go. So anyway, a quick foray through a few conditions today, trying to fill in some of the holes in our YouTube library. If you have any questions, please feel free to reach out at any time. And again, as always, if you have any suggestions of entities that you'd like to see covered, please let me know. Oh, and April just put a note in there, mark your calendar. Our next Sagis Dermpath core exam review will be January 29th. Thanks, and hope everybody has a great week. Talk to you soon. Bye-bye.